discuss couple of the things before we start our the formal discussion on today's topic, which is tuberculosis, management of tuberculosis in pregnancy. Okay, so you guys know me, almost everyone who is here know me that I'm Dr. Zaib Qureshi, right? So I'm a senior mentor at MedExam Expert, and at the moment, MedExam team is with me, and I wholeheartedly thank them to for arranging such webinars for all our candidate, okay, who can listen to us, who can watch even later as well, who can even the help. These webinars can also the help them in their ongoing studies as well, okay, because tuberculosis is a very important topic, and these days, because it is relatively new TOG article, so the chances are that in January exam you can get one or two question. Okay, hi Vasvi, how are you? So I know everybody is preparing for part two, and somewhat everybody looks so overwhelmed and kind of upset, kind of lost, and which is kind of natural, isn't it? So I have been there. I am the teaching for quite long, and of course I know what exactly the students feel while they are in MRCOG to the journey, because of the syllabus, which is kind of never ending, and of course it is a bit overwhelming as well, because we have to cover so many things, we have to cover so many the topics, and of course we have to revise them as well later. So keeping in view that we have to cover so many things, and keeping in view that of course by the end we really want to succeed in exam, and we want to enter in part 3, and then we all want to become MRCOG. Okay, so I am going to start my today's session with one of the the beautiful the thing, because apparently everybody thinks that success is very easy, but nobody thinks that because so many people ask me as well that, Dr. Zaib, you have done FCPS, you have done this. So was it easy? No, it wasn't easy at all. It wasn't easy at all. Okay, so of course the apparently it looks so fascinating. I'm sure many of you they must be thinking that a person who is holding all these degrees or the certificates must be like, I mean, kind of the it must be kind of easy for him or her, but trust me, it wasn't. Okay, so almost every exam the have been difficult. Every exam the success looks very the kind of fascinating by a single outlook, but it is a kind of the pyramid of hard work, persistence, late nights, late nights in terms of, because we all are doctors, we are working, and of course we are in hospitals at times, we are sometimes we are on night call, sometimes on we are on day duty. So this way or that way, when we have to study, so of course we have to study out of our every the responsibility whatever we are doing, plus our duties, hospital job as well. Then rejections, sacrifices, discipline, criticism, doubts, sometimes failure, sometimes we have to take risk as well. Okay, but if we overcome each and everything, what we get eventually? Success, of course. And it looks so beautiful when you finish your one journey, when you attain your one certificate or one degree. So yes, of course it looks so good and beautiful in the end, but altogether what you need to do is that you have to cross this pyramid. Okay, you have to sail this difficult journey with all the hard work, persistence. Okay, because it's not like that just aiming part 2 is going to pass you, but of course the studying for part 2, giving your 100% for it, and of course not giving up. This is another the thing, because most of the time what happens is that sometimes we get so upset and we really want to give up. So giving up should never be an option at all. Okay, so giving up, when you give up on something, it means that you are giving up on your dream. So if you are in this MRCOG journey, so always think of, why am I doing this MRCOG? What exactly is the benefit of this MRCOG to me, to my life and all. Okay, so again I would like to conclude this slide that giving up is not an option at all. Okay, so you have to work hard, you have to work smart as well. At all times you need to stay focused, because part 2 is difficult. Okay, it's not going to be a piece of cake. You have to work hard, because you have to the cram up so many guidelines, TOG articles, and then you have to have a lot of practice of questions as well. Okay, So make sure that you are thinking on this pyramid every day and you are working towards your success, which is your ultimate goal in this MRCOG journey. Okay, so moving forward, we are going to discuss this tuberculosis in pregnancy, which is relatively new TOG article of 2023 of July, the issue. So we are going to discuss this tuberculosis in pregnancy. Okay, so how many of you have read this TOG article and how many of you could find it easy or difficult? What are your thoughts about it? Has anybody had any, the chance to go through this TOG article?
No.
No? Okay, because you were waiting for me, right?
Yes.
Okay, no worries. We will discuss it today. And of course, when we are going to start any disease, we need to know that what exactly is that disease, what is the etiology, pathology, physiology, and then of course, we are going to treat. And since we are dealing with OBG, so things are going to be related to pregnancy as well. And when we talk about pregnancy, of course, we need to see so many things, not only the pregnant individual, but upcoming baby as well, isn't it? So, of course, we are going to cover so many things from this TOG article. And according to me, I will try to highlight which I think as a teacher is important for exam. Okay, so let's get started with. So the background, tuberculosis is relatively, the disease of underdeveloped population, isn't it? But because of the massive, what you can say, that the people are migrating, people are being the in UK for quite long now, so most of the time the burden of this disease is getting high in the UK as well. Otherwise, this has always been the thought that tuberculosis is the disease of underdeveloped or resource limiting countries. Okay, so most of them are to be found in the Africa or Southeast Asia. And unluckily, the subcontinent is very rich in tuberculosis because of the high, the load of population and less facilities and lack of awareness as well. So many things, right? So infection with tuberculosis in women with reproductive age accounts for a significant burden in these settings. And sometimes, if at all, it is with co-infection with HIV, because we all know HIV has got a lot of immunodeficiency in the body, right? So HIV individual is going to be immunodeficient, and HIV is going to invite so many sinistrous, the pathologies and organisms, viruses, bacteria, and everything in the body. And they will wholeheartedly welcome. So tuberculosis among pregnant women can adversely affect the health of mother, fetus, neonate, and child as well, with a wide spectrum of short and long-term complications, including pregnancy loss, preterm birth, leading to an increased risk of maternal and perinatal morbidity and mortality. TOG says that the global burden of tuberculosis, WHO, according to, because we are, the following WHO, the kind of criteria on this tuberculosis, because WHO as an organization is working, the all around the globe. So it says that in the Africa, it is the highest burden, okay, then America, then East Mediterranean countries, Europe, Southeast Asia, then, the Western Pacific countries as well. So simply you can just, think of that it is the prevalence of TB is high in the resource limited countries. Doesn't matter what exactly, where exactly the country is, because if it is resource limited, okay, so yes, prevalence is going to be high. So in pregnant individuals, it is the exact prevalence is unknown, but multiple sources has suggested an increased incidence among women of reproductive age group. So prevalence of the TB among pregnant women ranges from 0.06 to 0.25 in low prevalence countries. So when you are going to jot down your points, your number one point is going to start from here, because I get several messages on daily basis that how to read TOG article. I think I have spoken about how to read TOG article a couple of times, but yet again, I'm going to revise that according to me, what I believe is important and what can come in exam as a question, okay? Because sometimes TOG article questions are going to be in exam, and they are relatively, the easy targeted, and most of the time they are going to be single best answers as well. So we all know from our, the background knowledge that Mycobacterium tuberculosis is the organism. Okay, otherwise mycobacterium has got a wide, the variety and class, because basically they are divided into mycobacterium tuberculosis, then mycobacterium leprae as well, then the various type of mycobacterium. I'm sure you all know that, right? But we are going to talk about only tuberculosis of lung today, and some of the extrapulmonary tuberculosis as well. So it belongs to the family of Mycobacteriaceae and is a non-spore forming aerobic. Aerobic mean that it is dependent on oxygen, and it is non-motile bacillus. So primarily it's an airborne infection. But infection can also through ingestion of unpasteurized milk and direct implantation through abrasions in the skin or conjunctiva. So it means this can be, the direct question as well, that what are the sources by which TB is going to be transmitted to one human to the other human. So in most cases, the immune system can clear the infection, but in those it fails to clear, it remains dormant in the body without any clinical manifestations. So if the disease is going to be dormant in the body without showing any sign and symptoms, so it is going to be termed as latent tuberculosis infection. So in this talk article, we are going to be using this terminology as well, LTBI. Or if may cause symptoms within weeks, months, or even years, then it is going to be the active tuberculosis. Approximately 10% of immunocompromised individuals with latent TB will develop reactivation of TB because they are immunocompromised. So they can get this TB activated anytime in their, the life. And similar percentage of healthy adults will acquire infection during their life as well. Okay, so yes, you can jot down this point, if you have your concept clear about this, so you can leave this. If somebody wants to just, the recap their background knowledge, so you can write this part as well and this part as well. So tuberculosis, we all know that this is, the disease of, the lung, and apex is going to be the reservoir or the house of the tuberculosis, because this is the apex of the lung is going to be the highest where the oxygen content is there. Because TB, tuberculosis organism, needs oxygen to be there in the body, so and replicate and cause a disease, active disease. So yeah, it is going to be found in the, the apex of the lung. So the outcomes for a primary infection with tuberculosis is going to be latent infection TB, which is going to be LTBI. It can be asymptomatic and it is going to be non-infectious. Then it is going to be primary TB. If tuberculosis shows disease within 2 years of infection. Secondary TB, those with immunosuppression, such as women with HIV or immunotherapy drugs or with autoimmune disorders, are more susceptible to reactivation of latent infection and more prone to extrapulmonary TB, especially during pregnancy. Makes sense? Because pregnancy itself is immunocompromised state. Yeah. So 20% of active TB can present as extrapulmonary TB. Good, the source of what you can say knowledge. The most common extrapulmonary disease in pregnancy in the UK occurs in cervical lymph nodes. See, it can be a question that which part of the body or which lymph nodes are involved in the extrapulmonary disease in pregnancy in UK. So it is cervical lymph node, which accounts for almost 31%. The other common sites can be the CNS, spinal cord, abdomen, and pericardium. See, is it making sense? Are you guys making a story in your head that, okay, this is how it is going to be? First, we have learned about its origin. Then we are going to see that what are the types. And then we are going to see how is it going to affect pregnancy. Clear so far? Very easy and very conceptual. So how, the tuberculosis presents? Can anybody tell me what are the signs and symptoms of tuberculosis?
Ma'am,
Common
cough, fever, night sweats, weight loss.
Cough, fever, night sweats, weight loss, any other thing? Yes, very good.
And
Hemoptysis, yes. Hemoptysis, yes. Because if cough is there can be hemoptysis with this lung abscess, yes, new thing. Pleural effusion,
Fatigue.
yeah. Fatigue, yes, because it's a chronic illness, yes. Okay, so
SOB, shortness of breath.
shortness of breath, yes, why not? Consolidation of the lung, fibrosis, yeah, in later stages of tuberculosis. Okay, if I ask you, does tuberculosis sign and symptoms will change in pregnancy or is it going to remain same?
Can be changed.
can be changed. How? How?
As in
How?
pregnancy,
Mhm.
as in pregnancy, there are the matlab, common symptoms like fatigue.
Mhm.
Is also common in the pregnancy and exertion as well.
Mhm.
So it might be confusion with the pregnancy symptoms and the normal pregnancy symptoms and the TB as well.
Exactly. So the sign and symptoms, of course, are going to be same, and it is going to be very difficult to diagnose. Like, I don't know your name, sweetheart, but yes, you brilliantly mentioned that, yes,
Dr.
because the
Aisha.
pregnancy, Aisha, okay. So in pregnancy, what happens is pregnancy is a state of respiratory alkalosis. Already there is going to be breathlessness, there is going to be sometimes, the woman may present with increased respiratory rate. Physiologically, there is increased respiratory rate as well. So sometimes it is going to be like, the kind of difficult to diagnose, but sign and symptoms are going to be same. Okay, so how you are going to think of that, okay, this pregnant woman is having active infection of tuberculosis. So of course we are going to check that what exactly are the signs and symptoms then, and how we are going to diagnose as an OBG, right? So it says, TOG says that TB can affect almost all organs and may present with non-specific symptoms. It should be suspected when there is a history of exposure to patients with chronic cough or recent visits to area endemic with the tuberculosis. Like I said earlier, because, somehow there are some areas which are endemic with tuberculosis, which are, the grossly populated, of course, we can always think of, right? So diagnosis may be delayed in pregnancy owing to the symptoms overlapping normal physiological changes that occur in pregnancy. Okay, except for the fever, symptoms are like that of tuberculosis in non-pregnant individual, including weight loss, night sweats, chills, loss of appetite, tiredness, weakness, which may be harder to label as pathological in pregnancy. See, except for fever, because fever is always a sign of what? Acute inflammation, isn't it? Fever, pain, nausea, vomiting, diarrhea, these all are signs of acute inflammation. As lungs are commonly affected, so we will see chronic cough, which is more than 3 weeks, chest pain, or hemoptysis may be the presenting feature as well in pregnancy. The primary physician may also have attempted to treat the infection with antibiotics prior to presentation. And I think this is a worst dilemma of, the ignoring this tuberculosis, because we always think that, okay, patient is having, the seasonal flu, cough, something like that. So yeah, we do ignore. Okay, so at all times when we are taking history from patients, so we need to ask that, has she had any recent visit to any area which is endemic to TB? Has she had any exposure to the patients with chronic cough, okay, in the family or in the friend circle or in the nearby, wherever she works? So WHO suggests a 4 symptom screening in pregnancy: fever, night sweats, cough, and weight loss.
Over the counter helps you.
Okay, so the sensitivity and specificity of this test to identify active TB in pregnant women is yet to be proven. In cases where there is a high index of suspicion, it may be worth conducting the diagnostic testing guided by the symptomatology of the individual patient, as missing the diagnosis increase the risk of perinatal morbidity and mortality, of course. But always think that these 4 things are going to be important to screen somebody with having tuberculosis. Okay, now if I ask you that, how you are going to diagnose tuberculosis, okay, uh, taking history is one of the, the important thing. Then how do you manage the case?
Sputum acid phosphorylated.
Okay, and what else?
We have to examine the chest properly, clinical history
Full
examination.
blood count. Okay, very interesting. What will you see in full blood count? Is it going to be specific or is it going to be non-specific? Chest X-ray be shielding. Okay. So do you think that chest X-ray will directly tell you all the findings of tuberculosis at first place? Or you have to
No,
screen or you have to diagnose first? Yes, chest X-ray can be helping modality. Examination of chest, full blood count. Okay, my question remains same. What exactly the full blood count will tell you?
neutrophil
नहीं,
Actually, ma'am,
TB is a
pregnancy
disease of
itself.
macrophages, तो वो देख लेंगे
Yes, sir.
lymphocyte लीटोपीनिया हो जाएगा, मतलब TLC काउंट, बेसिकली DLC काउंट देखना हमने TB में.
Mhm.
pregnancy itself has little high leukocytosis, ma'am. So it is
Exactly.
difficult to diagnose.
It's difficult to diagnose on the basis of
Diagnose.
leukocytosis, because up to 6,000 or even 10,000, we take it as normal. Because when we say it is absolute leukocytosis, it is going to be more than 10,000, isn't it? But in pregnancy, obviously, there is going to be, the state of leukocytosis. So not only leukocytosis, but full blood count can be baseline, but it is not going to help you in your disease. Okay. So relatively, when somebody is asking you, what are you going to offer? Name the investigations what you are going to offer. So when we talk about investigations for the tuberculosis, we are going to classify them as number one, screening test. Then, of course, one. And why we offer screen? We always offer screening test to those, the diseases for which we do have confirmatory test as well. This is rule, right? So for screening test, we do TB skin test, Montox test, right? So then we do IGRA, which these days is not being preferred. Okay, interferon gamma released assay. This is just screening. Then we do confirmatory test on the basis of microscopy and culture and sensitivity. Okay, then we do additional test as well, additional test in which, the X-ray is going to be there, CT chest is going to be there, and the other test as well. So let's take one by one. So how do we do the tuberculin test, the skin test? So it will going to involve the PPD injection, okay? So it will be given intradermally. Then we are going to check the reaction between 48 to 72 hours. Okay, we are going to check in terms of in duration. So it has to be between 5 to 15 in duration. That will tell us that, okay, this person can have, the tuberculosis suspicion. Pregnancy, now this is your exam question. Pregnancy does not alter the outcome of the result, and as PPD is not infectious, and it can be safely administered to both mothers and babies as well, because we are dealing with pregnancy. Okay, so it means if we are having high suspicion of tuberculosis to any pregnant lady, we can offer her tuberculin skin test as well. There are two types of TST, Tyne and Montox. So Tyne test is rarely used these days, but Montox is the most frequently performed. False positive results can occur and false negative can occur as well. False positive can be seen in women with previous BCG vaccination, previous tuberculosis infection, and infection with non-tuberculosis mycobacterium as well. False negative can also occur after technical issues and in women with recent TB infection, immunocompromised status, sarcoidosis, non-Hodgkin lymphoma, and recent live vaccination with measles and chickenpox, because these both are, the active infection or active vaccination. So of course, they are going to give body and, the active disease state. So this tuberculin skin test has recently replaced CTB skin test, means Statin Serum Institute, and this is from the company by the Denmark, has recently replaced PPD owing to the global shortage of PPD. But still, the value of it is yet to be seen in our the clinical individual. So yes, we are going to just name Montox test. Okay, TB skin test, and most commonly used is Montox. Then IGRA. Okay, so IGRA will detect what? It will detect, because it is gamma release assay, so it will detect the cell mediated immunity. Okay, so how it is going to detect a cytokine called interferon gamma, which is produced following stimulation of tuberculosis specific antigens. IGRA tests are developed using Mycobacterium tuberculosis, unlike the BCG vaccination, which utilizes the Mycobacterium bovis strain. Therefore, IGRA is not influenced by BCG vaccination. Okay, so although IGRA is not validated for use in pregnant individual, it is routinely performed in pregnancy. And like the CTB skin test, IGRA does not differentiate latent from active infection. Moreover, in clinical settings, many clinicians use IGRA for latent TB infection, but not the active infection. Okay, then if we have screened, if we see that somebody is screen positive, we are going to go for diagnostic test. So we are going to do microscopy. Microscopy is going to be acid-fast bacilli or Zeal-Nelson staining. We all are well versed of it since our graduation times, isn't it? Other techniques is Kinon testing and the recent fluorescent testing using auramine, rhodamine, which have been improved the rate of TB diagnosis. But still, the clinical evaluation is yet to be determined. So according to WHO, the sputum positive cases accounts for between 56 and 86% of pulmonary TB infection. So these screening techniques may miss 1/3 of the active diseases as well. So other techniques can also be there. LAM is there, RIFD is there, but still, the validity is yet to be determined. So histology of an affective organ may show granulomatous reaction with epithelioid cell granuloma with Langerhans giant cells and caseous necrosis in the center. And what we call it, if we see, what we call it, anyone? I'm sure the part 1 people know this. Gone reaction. Gone focus is in lung, okay? This is going to be gone reaction, okay? When we are going to see on histology. So culture and sensitivity, then we are going to do, which is, the LJ media. We do it, the Lowenstein-Jensen media. It is a traditionally used for culture and sensitivity of the Mycobacterium tuberculosis. Culture may take 4 to 8 weeks. It is going to be long, okay? Then drug sensitivity results may take further 6 to 8 weeks again. So solid culture media are now replaced by the liquid culture media these days. The various techniques are there, but still, we need to know about their clinical, the relevance. The other diagnostic tests can be real-time PCR and the line probe assay, LIPA. The results of these tests can be read within a couple of hours, and these tests can identify resistance to both the first and the second line drugs. But again, the availability, the sources, of course, not every center is going to be very well equipped with the new modalities. So imaging studies, chest X-ray is a good screening tool and should be used in pregnancy when clinically indicated. It confers low radiation exposure to the fetus when used with appropriate shielding, and it can be useful in active pulmonary infection, which may show patchy or the nodular shadow, which can show miliary shadow, fibrosis, loss of lung volume, or cavitation, and which is going to be most commonly in the upper zone or middle zone. So a primary focus can be seen in the latent disease. So chest X-ray may show gone focus, which is granulomatous reaction in the middle or the lower zone of the lung with transient hilar or the paratracheal lymphadenopathy, with or without superimposed pleural reaction. So sometimes in treated individuals, and 14% of culture-positive tuberculosis patients can have normal chest X-ray as well. So almost all these are going to be helping modalities in diagnosing and treating tuberculosis. However, our main, the diagnostic tool for, the confirmation of tuberculosis remains microscopy and culture, and the microscopy and culture and sensitivity. So this is what we see, gone focus, right? A primary lesion using subpleural, often in the mid or the lower zone, caused by the Mycobacterium tuberculosis. Okay, so this is going to be there. Then ultrasound can also be done. Sometimes if we really want to do any aspiration, okay, we want to do, so it can be safely performed in the pregnancy as well. So, that can be performed. So now, like as a rule for the maternal medicine disorder, we always study any medical disorder in two, the parts. Effect of pregnancy on tuberculosis or disease, and effect of disease on pregnancy. So we will cover one by one. So first we will see effect of pregnancy on tuberculosis. So immunological changes during pregnancy increases susceptibility to tuberculosis, meaning that the women of reproductive age are at increased risk of primary TB or reactivation of TB. So pregnancy can also make the diagnosis of TB more challenging, which we have discussed earlier. The postpartum period is observed to have an increased risk of reactivation, because the postpartum period is again going to be the very vulnerable phase. And the susceptibility of women to TB during this period is higher than in the non-pregnant individual with these similar demographics. There is no alteration in the susceptibility of different sites of TB infection in pregnancy. The course and prognosis of TB in pregnancy are determined by, number one, severity of disease, susceptibility to the medications, and organ involvement, as well as the individual susceptibility based on the presence of other disorders as well. So predisposition to immunosuppressive states such as HIV co-infection is more likely to lead to progression to active disease. So what we need timely diagnosis and installation of treatment without delay can improve the outcomes, because we are worried about mother as well as baby. Then effect of tuberculosis on pregnancy. The maternal and neonatal outcomes will depend on, again, stage, gestational age at diagnosis, treatment they have received, presence of extrapulmonary spread, co-infection with HIV, and the presence of morbidities as well. So what do we see in pregnancy? Sometimes there can be, the late presentation, there can be delay in diagnosis because of the non-specific and vague symptoms. We can see anemia in 41% of cases. We can see prematurity in 32% of cases. Okay, so the antenatal oligohydramnios in certain studies have been seen as well in the women with active TB, but not with the latent TB. So they also have been seen, it has also been seen that they had 2 maternal deaths as well. So genital TB was 50% of extrapulmonary cases, which we have said earlier that in pregnancy, this is going to be more prevalent. So to conclude again, how it is going to affect the stage of the disease, the process, gestational age at diagnosis, treatment received or no, was there any presence of extrapulmonary spread? Was there any HIV or any other comorbidity as well, such as long-standing, any diabetes, autoimmune disorder? Because altogether, they will decrease the immune response as well, isn't it? Then, how do we do in pregnancy? How do we manage suspected pulmonary tuberculosis in pregnancy? So we will suspect pulmonary tuberculosis on the basis of signs and symptoms. If we see that, yes, there are signs and symptoms, then we will find them as active TB. We can go for chest X-ray shielding, sputum samples 3 times, okay, 3 sputum samples early morning. But it has to be associated with sputum, not only, the normal, what you can say, secretions. Microscopy and culture and drug susceptibility testing later on. Then, of course, because we are dealing with, the pregnancy as well, then we are going to deal with this patient with the help of multidisciplinary team approach, including tuberculosis physician or respiratory physician. Of course, we are going to start anti-tuberculosis treatment as well, ATT. Right? So if patient is not having at the moment symptoms, but she is a strong suspect of pulmonary tuberculosis, but she's not having any active sign and symptoms, we may label as latent TB. We can go for test, okay, TST, tuberculous skin test, or IGRA. So either of them, if it is positive, we will suspect active tuberculosis. If we suspect, still we suspect active tuberculosis, so the treatment will be the same. If there is no active tuberculosis, so treatment is going to be for LTBI. Clear, everyone? This part, very, very easy. Everyone, is this clear? So this is all how, the number of investigations and how we are going to investigate and diagnose. All right, brilliant, brilliant, good. So like we said earlier, that extrapulmonary TB is very common, 50% in pregnancy. So what exactly is going to be the extrapulmonary TB and the organs? Of course, we will take system one by one: abdominal TB, CNS TB, cutaneous, genitourinary, lymph node, musculoskeletal, ocular. No need to go into the detail, because as a doctor, almost we all are so well versed with almost all these organs and how they can present. Our main aim should be that how we are going to diagnose and treat in pregnancy. Okay, so of course, if it is abdominal, patient will present as pain, nausea, vomiting, altered bowel habits, and we can see abdominal mass, pain, ascites, jaundice, hepatomegaly, hematemesis. And you can see that these are not pregnancy symptoms, right? So we may go for ultrasound, endoscopy, CT abdomen, MRI abdomen, biopsy, culture, and drug susceptibility. And so, after one by one, we are going to, the check. And treatment is going to be accordingly as well. Then, if a person is having HIV tuberculosis co-infection, which we have said earlier, that HIV is going to, they invite so many sinistrous, and dangerous organisms towards, the individual who is having HIV. Okay, so HIV positive pregnant women who also present with TB, diagnosis and treatment is going to be challenging, owing to overlapping symptoms, drug toxicity, side effects, tolerability, and pharmacokinetics of the drugs administered. Women with co-infection are at high risk of multi-resistant TB. I think it can be a question, multi-drug resistant tuberculosis and disease relapse as well, following completion of the treatment. Because it's an independent risk factor for reactivation of TB as well by 20-fold. It can be single best answer, isn't it? Seems important. So co-infection can lead to increased risk of anemia, eclampsia, placenta acreta, drug abuse, and depression as well. Psychological comorbidity can always be there with every long-term illness. So how do you treat? Of course, so treatment is also important. If we leave it untreated, so the baby and the mother, they both will have the greater risk on their health, okay, and the upcoming baby as well. So TB needs to be investigated, diagnosed, and treated as well. So when TB treatment is initiated earlier in the pregnancy first trimester, the risk associated with preterm birth, low birth weight, perinatal death are almost eliminated. See, because the initial, the therapy is going to be almost eradication therapy, and then later we keep them on continuation therapy. So similarly, maternal complications are also decreased with early initiation of treatment when compared to the commencing treatment in the second and third trimester. Always it is going to be MDT approach. Pregnant women who are suspected of active TB, now see, or those from the high risk group for the TB should be assessed as per the standard manner. Accordingly, we are going to take history, we are going to see from where exactly they are coming from, okay, which country they do have origin, any recent visit to any endemic area. All right, then their own, from history, we will find out if they are having any kind of comorbidity or no, or HIV, the infection or no. So almost all these things are going to be assessed. So investigations should be considered for pregnant women with either had a recent exposure, such as in their household or through another close contact, occupational or social, or who are in any immunocompromised state. So treatment is going to be initiated based on the disease status, if it is latent, active, or the drug resistant TB. If it is active, how we are going to treat? I'm sure we all know, since our the medical the basic MBBS or the the studies, we all know that we have got a couple of drugs. Everybody is well versed of INH, okay, isoniazid, rifampicin, pyrazinamide, and ethambutol. We do give them, right? So the treatment is going to be same. So how do we give? This is very important. So in the form of active tuberculosis, the risk of untreated TB outweigh the risk of adverse effects affecting the ATT. So treatment should be initiated as early as possible. Number one rule, according to NICE, treatment of TB in pregnancy is like in the non-pregnant woman. So don't think of that. We don't have to give all these, the medications. But yes, duration and the dose are not altered because of the pregnancy or even according to gestation as well, because we have to treat individual. So once it is established, so the treatment of TB which is not involving CNS, should include, INH, rifampicin, pyrazinamide, and ethambutol for 2 months, initial phase, 2 months, followed by in INH and rifampicin for 4 months, continuation phase. You can see in pregnancy, they are giving for 6 months. 2 months is the initial phase, which is going to be kind of eradication phase, and then there is going to be continuation phase. If CNS is involved, very dangerous. So the recommended treatment is going to be for 1 year. And then we are going to involve INH, rifampicin, PISA, we used to call it as pyrazinamide PISA, and ethambutol for 2 months. Then INH and rifampicin for 10 months, because we are treating CNS TB. Okay, clear everyone? In pregnancy, if CNS is not involved, the treatment is going to be total 6 months, like every non-pregnant individual. If CNS is involved, then treatment is going to be for total 1 year. Okay, now pyridoxine should be given. Why do we want to give pyridoxine? Okay, let me just check your basic pharmacology. What is the most common side effect of INH?
Peripheral neuropathy.
Yes, we used to call it as, because it is INH, so it injures neurons. Okay, it injures neurons. So that's why we have to give them pyridoxine. 10 milligram per day is given with INH during both the initiation and continuation phase, because even in the requirement in the pregnancy is going to be changed. So we have to prevent from neurotoxicity. Okay. So what is going to be the most common side effect of rifampicin?
hepatotoxin.
And it colors the urine, dark
Yes,
yellow
orange
color,
color.
orange color urine. And this is going to give, the patient an anxiety as well. So we have to tell them that, look, your urine may turn into, the different colors, so you don't have to worry about that, right? Isn't it? Then pyrazinamide, sometimes it can be ototoxic. Ethambutol is ototoxic as well. Okay, plus hepatotoxic, because every drug is going to be metabolized by liver and then excreted by kidney as well. Okay, so we need to make sure that at least our basic, the concept is clear as well. Okay, so coming back to this, that we are going to give pyridoxine, and for the pregnant woman with CNS involvement, adjuvant steroids with either dexamethasone or prednisolone is given. Okay, so we have to give them this. So this is given over 4 to 8 weeks with a gradual tapering of the dose. In such cases, stress dose of steroids should be considered in labor, because by rule, if any woman who is having the more than 4 weeks steroid therapy, then in the labor we have to give them IV hydrocortisone to prevent the baby from adrenal crisis. So all first line ATT are classified as category C by FDA and are considered safe to administer in pregnancy with no proven teratogenic effects. Like, as a rule, almost all, the antibiotics and drugs are category B or C. However, if we say that it is class C, so we don't find any kind of proven teratogenic effects, so yes, we can give. The WHO, British Thoracic Society, and the Centers of Disease Control Prevention USA consider the first line ATT safe to be taken during pregnancy, except streptomycin, which is going to be, the ototoxic, which will lead to neonatal irreversible deafness, 15% of cases. This can be questioned, right? Very important one, and very, the conceptual. That's why we don't give streptomycin. The majority of the women taking first-line ATT may not experience any adverse side effects. However, hepatotoxicity is a concern. The peripheral neuropathy symptoms associated with INH can at times be difficult to differentiate between exaggerated pregnancy-related symptoms as well. Because almost every pregnancy woman comes with, the numbness, pain, and, the muscle spasm and blah, blah, blah. However, we need to be very mindful when we are treating this tuberculosis.
Can you show the last line?
Then the second type is going to be drug-resistant tuberculosis. Okay, so if it is drug-resistant or multi-drug resistant TB, so then of course treatment is going to be, maybe regime is going to be changed. So if it is Mycobacterium tuberculosis resistant to one of the first line ATT except rifampicin, this should be considered as a drug-resistant tuberculosis. So duration will be, the altered. Initial phase is going to be for 2 months with 3 ATT, but the continuation phase varies between 4 to 7 months with 2 ATT, depending on the drug sensitive to the mycobacterium. If the mycobacterium is resistant to either rifampicin or to both rifampicin and INH, it should be considered as multi-drug resistant TB. Because basically rifampicin and INH both are going to be, the kind of backbone of the treatment of tuberculosis. If it is extensively drug-resistant TB, beyond the scope of discussion is this in this article, of course, because we are not, the internee at the moment, internal medicine specialist. However, we just need to know that as an OBG, what is our responsibility to diagnose, to investigate, and to start the treatment with the respiratory physician. The third type is going to be the latent tuberculosis. So pregnant women with latent infection should be considered for prophylaxis if they are HIV positive or are high risk of having TB recently. For example, they are coming from the high prevalence country, close contact with person or pulmonary or laryngeal TB, or after investigation as well. Delaying the treatment to the second trimester is not recommended at all. It means that as early as possible, the treatment should be instituted, so we can, treat the woman as well, and we can reduce the chances of having, the multiple problem to the baby as well. So the treatment of latent TB is INH with B6, vitamin B6 for 6 months. This is important. or a combination of both INH and rifampicin for 3 months only based on individual clinical circumstances. See, now you guys can see the, the difference between different type of TB. Active TB, we have to give for 6 months without CNS involvement. If CNS involvement is there, then total 1 year. If it is drug resistant, then of course, the initial treatment phase is going to be remains, the same with 3-ATT, but in continuation phase, we can take it up to 4 to 7 months. If it is resistant to rifampicin and INH, then it will be termed as multi-drug resistant TB. Okay. Then latent TB should be treated with INH for 6 months. INH with, of course, if we are giving INH, we have to give vitamin B6 as well, or either we have to give combination of INH and rifampicin for 3 months only. Hepatotoxicity associated with INH could be expected in the 3rd trimester or early postpartum period. However, these risks are balanced by the risk of developing active tuberculosis, because this latent can convert into active TB anytime. So we need to balance. And of course, when we are going to ask them, so we all know that with INH, alcohol should not be given and other recreational drugs as well. So we will ask them not to use alcohol, and we will ask them not to do any the drug as well. So then INH prevention therapy and HIV positive pregnant women. The WHO recommend initiation of INH preventive therapy along with ART, okay, antiretroviral treatment in HIV positive pregnant women who are not diagnosed as latent TB due to adverse risk of TB during pregnancy. So this recommendation is based on non-pregnant population and more evidence is needed. So, but this way or that way, we have to give them. So how about perinatal tuberculosis? Does it going to be transmitted to the baby? So perinatal TB include TB acquired congenitally or postnatally. So the treatment and prognosis of both forms of perinatal TB is the same, and the classification is going to be epidemiological justification only. TB acquired by the fetus in utero, either antenatally or intrapartum, is considered as congenital TB. It is acquired by the fetus in utero either through placenta, amniotic fluid, umbilical vein, when the mother has active TB. So of course, in active TB, mother can give TB to the baby. Neonatal TB is most likely to occur in the postnatal period, because now the fetus is out and baby will be termed as neonate, and usually acquired in the immediate postpartum period. And of course, when neonate comes in close contact with an open active sputum positive case of TB, again, because now baby is born, so baby will be considered as, this another, the individual. So if the baby has had exposure to the sputum positive case of TB, yes, there are chances that neonatal TB can be there. Primary focus in neonate is liver. This is important. In liver, we can see hepatic granuloma on abdominal scan and the periportal lymph node lymphadenopathy as well compared with the adults. This can be the question if at all it comes in exam. In whom it is most commonly observed in the lungs, miliary pattern is the commonest finding on the chest X-ray in neonate. Perinatal TB again is going to be diagnosed by the placental histology and culture. Chest X-ray can be useful, the pathology. However, the CSF culture and sensitivity can also be done, and rest, the high order investigation as well. So how do you diagnose, the perinatal TB? It is important. So diagnosis is going to be demonstration of the lesions in the newborn in the first week of life, primary hepatic complex or caseating granuloma on percutaneous liver biopsy at birth, placental or maternal genital tract TB, or excluding the likelihood of transmission of postnatal contact. So if there is a chance of perinatal TB, it will be giving a high mortality rate for both treated and non-treated infant. Treatment of active disease is like that of an adult, along with the pyridoxine supplementation to prevent seizures associated with pyridoxine deficiency. In the presence of active maternal TB, and if there is no clinical or laboratory evidence of perinatal TB, INH preventive therapy should be given for 6 months along with pyridoxine. I think this is important. The decision to breastfeed should be taken after a MDT meeting. ATT, anti-tuberculous medication, is excreted in small amount in the breast milk with no adverse consequences to the baby. And it is considered to be safe if the mother has completed at least 2 weeks of her treatment, because expected time for seroconversion to the sputum negative. This is that. So breastfeeding is usually not recommended if there is evidence of breast TB, of course, if there is evidence of multi-drug or extended drug-resistant TB, or if there is co-infection with the HIV. But if it is, the active TB, but provided if the woman has taken 2 weeks of her treatment, initial 2 weeks of treatment, then yes, she can breastfeed. Again, the decision to breastfeed is going to be after MDT meeting. Okay, clear everyone? Very beautiful. And, I must say that very beautifully written TOG article, which is important as well. Clear everyone? Good job, good job, good job. All right. So what about BCG vaccination? Because now baby is born. So of course, sometimes, because we do give BCG vaccination, okay, against TB to every individual. So WHO recommends that in countries with high prevalence of TB, a single dose of BCG should be given to all neonates as soon as possible after birth. In the UK, BCG is vaccination for neonates whose parents or grandparents were born in a country where the annual incidence of TB is 40 by 100,000 or greater. Okay? Or if a newborn baby is living in areas of the UK where the annual incidence of TB is, 40 by 100,000 or greater. So it all depends on that. So in UK, it is not routine, but of course, they will have all data that either they are migrated or, the asylum seekers or what. So of course, they are going to give accordingly. So the providers are required to check for the record of the negative serum, the combined immunodeficiency, the testing in the individual, then they will give, because BCG gives acute, the reaction, and it may mimic the active TB as well. So it is important that we should be, confirmed that baby is not having any immunocompromised state. So BCG vaccination should be avoided in pregnancy because it is a live attenuated vaccine, and it is contraindicated in infants exposed to immunosuppressive treatment in utero or in breastfeeding children with an active TB cases as well. So for infants born to HIV positive mother, BCG should be given if the child is HIV negative at 12 to 14 weeks. So HIV is a complete different spectrum, because we do test, the newborn up till 18 months of the age. So then, of course, according to the HIV physician and neonatologist, we are going to give all vaccinations accordingly. So duration of immunity provided by BCG against TB is not fully established, but studies have shown it may give protection against severe TB in children and to a certain extent in adults as well. But again, there is also a difference in the immune response to the BCG vaccination depending on race, and there may be a wide global variation in the immunity as a result as well. However, presence of a BCG scar doesn't exclude latent or an active TB infection. I'm sure you all know that, almost all of us, all of us have BCG scar on our, the arm, isn't it? So this was all about tuberculosis in pregnancy and how we are going to manage percentage of transmission in newborn. It all depends on the woman, okay? So we cannot comment that, there is an exact percentage. Of course, if the woman was having, the genital tuberculosis, if the woman was having active tuberculosis, then it can be high, okay? But I could not find any exact percentage. But of course, it will be dependent on what exactly the woman was having at that time, okay? Active TB, first time diagnosis in pregnancy, or was there any extragenital tuberculosis? Was there any multi-drug resistant tuberculosis? So chances are going to be high. Of course, that makes sense, isn't it? Okay, okay, good, 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 good. All right, clear everyone? Anam, Abu Bakr, Anam, good to have you. Fatima, Jamila, Meeta, and Rakhi, Rosina, Sadaf, Sapna, Shireen, Sulafa, everyone. if you have read, if you have just, attended this session, I'm sure you won't need it. Okay. But still, if you really want to study it yourself, so try to take TOG article as a story. Okay. Like I always tell you guys. Okay. So take it as a story. Okay. This thing is starting from which point? Because as a student, we all know that every disease has a background. Every disease has a background. Which year TOG? It is July 2023. Okay. Recent. July 2023. All right. Okay, brilliant, brilliant. So I think this is an important TOG article, relatively new. So there can be, the questions from this TOG. So make sure that almost all medical disorders are well read and you know your curriculum and syllabus very well. So at least one should not be, they're having surprise in exam, right? So at least you should know. Can I share? Yes, sure. Why not? It is already shared on Telegram groups. We need more sessions like it. Okay, sure. I will request med exam team to schedule, and if we can, I can happily, the talk, because I love teaching. So I can always come, I can always teach. And I think studying one talk article cannot take, that much time. So at least we can discuss, we can meet. And apart from that, I'm easily approachable. You guys can reach me out even on Facebook, Telegram, WhatsApp, here and there, everywhere. Okay. So I may be delay in, the responding, but I will. Okay, this way or that way. Thank you. Thank you so much, Aisha. It was very nice of you having, the insight of tuberculosis and, if you, again, I may sound repetitive, but if your concepts are clear, exam is not that difficult, because it doesn't matter, if you are, talk very difficult. No, it's not difficult. It's not difficult, Sulafa. I would suggest that, take TOG article as, a story, like we did today. Okay, that we have started from, the pathogenesis. We have started from, the basic microbiology, how we are going to investigate, how we are going to, the diagnose in the, the patient in the pregnancy, basically. Okay. So of course, if you are going to study like this and make rules for your studies, because I love teaching maternal medicine and my students know me and my students know that as well. So I always tell all of them that for every maternal medicine disorder, okay, every medical disorder, in fact, you have to, think of two things: how this disease is going to affect on pregnancy, how pregnancy will affect on disease, and what about fetus. Okay, then of course the treatment. So if you will make columns like this, like I used to do while I was a student like you, okay, but of course, but now I am at a point where I can read one talk article in, like, 15 to 20 minutes. If I really need focus, I can take 30 minutes, 1 hour as well. But trust me, talk article do not take more than 1 hour. So I think, you guys can study. You guys can study and read this talk article. Not only this, but the other talk article as well. Okay. Hi, welcome, Umahani. No problem. Recording will be available, and I think it is live broadcast on Facebook as well. And you can watch right after, we are going to end this session. Okay. So it will be there. Don't worry about it. So this is going to be, the kind of golden tip from my side to all of you, that always study every maternal medicine disorder as disease, effect of disease on pregnancy, because pregnancy has some, the physiological changes as well. Then how disease is going to act in pregnancy, like for example, for asthma, we always, say very, the happily that we know about asthma, that okay, 33% will remain same, 33% will be, the exacerbate, and 33% will be like, decreased, severity will be decreased, right? 33, 33, 33, because of, the different pregnancy changes, because of, the one or the other reason. Okay. Is there any YouTube can? Yes, there is. Okay. So you can go to Sulafa, you can go to med exam. So I have had so many, the sessions. So all recordings are available over there. You can go to med exam expert. Okay. So you can watch as many time as possible. No problem. All right. So inshallah, I will catch you guys some other time, and perhaps we are going to continue these talks. Okay. So I will ask MedExam team to, arrange all these, the sessions for all of you, and we will meet till exam, inshallah. So this is my aim, that at least we are going to discuss like every fortnightly, maybe, okay, every 2 weeks. So we can discuss one TOG article properly, because we still have so much time left for January exam. Thank you so much, Vasavi. Thank you so much. Means a lot. Means a lot. Okay. Thank you so much, guys. Okay, anytime if you guys have any difficulty in part 2, part 3, part 1, wherever, so we are more than welcome to solve your queries, and I'll be happily, helping you anytime. Okay. Thank you so much, Habiba. It's always, so lovely to have you, and with me, of course, because I feel supported. Okay. Hi, Zoom user. I don't know who are you, but hi. Okay. So with this positive note that we don't have to give up, and we just have to study smart, study, the hard, and eventually everybody will be a MRCOG, maybe today, maybe tomorrow. Okay. So, but yes, inshallah, we all will be. All right. So don't worry about the hassle. Don't worry about the struggle. Just focus on word MRCOG. If it is going to be written in front of your name, MRCOG. So just imagine how it will sound, isn't it? So it will be beautiful. So I'm hoping to have you all, to see you all after part 2 in part 3 as well, or maybe in exam as well, because I'm part 3 examiner too. So let's see, what comes in the what comes next in the future. Thank you so much, Aisha. Thank you so much. Means a lot. Okay. So I will catch you guys some other time, inshallah. Okay. Stay tuned, and do subscribe this MedExam Expert, the channel, YouTube channel. So you will get all notifications. We do, the conduct so many sessions, okay, on regular basis. All right. Good night. Take good care of yourself and your loved ones as well. Okay. See you guys, inshallah. Bye bye.